to be up going towards, we just started the recording, so let's start this one again. Okay, do we need to get the initial eval signed? Yes, you do, even if it's on the plan of care. And it's not a bad idea to put it on the plan of care, but there's a lot of things on that, as I said before, that need to get to the doctor's attention. And most importantly, the narrative, manual muscle test, any kind of intervention changes. What that therapist saw is what the physician needs to be aware of, and they need to have a signature on there to prove that they are aware of it and that you've made them aware. So I apologize again, we're having a little bit of a technical difficulty getting Cindy on here. So Scott, where are we? Bear with us, everybody. I apologize for this delay. While we're waiting on Cindy and Scott to figure out our technical glitch, I wanted to bring something to everyone's attention. I'm going to go ahead and advance the slide. We wanted to take a moment to highlight some women-owned businesses that can help your agency. Many times at K&K, we get proposed a question or a consultation opportunity where we don't have the answers. So we have sought out and we've made relationships, and we have folks that we know, like, and trust, that we offer this information to you guys as a way to fully round out the services that your agency has. And as a woman-owned business, there's special challenges that occur with that. And we wanted to make sure that we highlighted a couple of other entrepreneurs that have gone into this space that can help. And the first one is TYM Coaching. We've had a long relationship with Dr. Miller. She is an expert in her field. She has a PhD in the social aspects of healthcare. And one of the things that she excels in is assisting healthcare leaders in improving their skills. And we have actually used her services at K&K to great benefit for us. And I want to tell you that if you're trying to build leaders and you're trying to understand what the best configuration of your agency is, many times a coach can assist you with that. And Dr. Miller is a former VP of Celtic Healthcare that actually was acquired by a PE. And so she comes from a ton of home health experience and actually kind of specializes in home health leaders and the special challenges that our area of care present. So take a moment, visit her site. You can use the website that's at the bottom, tymcoaching.com, or simply take your phone and follow the link at the QR code. She's very responsive, so reach out to her today and see if you can get some assistance. The other thing I wanted to mention, the other company we wanted to mention, and this is a new one for us, which we're so excited about this, Healthcare Office Solutions. The owner of this business is Lori Owens. Lori comes from a wealth of experience in home health and actually is very dedicated to assisting agencies in their processes from the moment you get a lead on a patient to when you take them into intake, when you get them through the process, plan of care, all the way through to the billing. And so setting up those processes, oftentimes in smaller to medium agencies, we have some difficulties because as leaders, every one of you wear multiple hats. There's not a soul on this call probably that doesn't have at least 2 or 3 different large responsibilities in your agency, particularly if you're of a certain size. And so taking a moment to visit the website for Healthcare Office Solutions and see what Lori and her team can do to help you is super important. And one of the things that Cindy and I, when we've met Lori and worked with her so far, is we like that she has the same morals and ethics that we do. And so I think that it's a really exciting thing for us to be able to offer, because they do on-site education, on-site training, on-site process development for your back office. Because it's one thing to see the patients clinically, it's a whole other thing to be able to get paid for them in a timely fashion and get paid what you should get paid. And also to avoid some of the compliance pitfalls along the way from intake of a patient to starting the care. So thank you for your patience in this time while we were delayed technically, and I appreciate it. And Cindy, I think you're here.
Yeah,
Yes, I am.
I just wanted to just let you know I was going to jump in. I was like, we got it. I couldn't hear you. I apologize for giving a heads up. I muted so that I could do the tech stuff without you hearing me in the background. So I apologize for that, but we got her in, everybody. We're good.
Scott's being kind, Sherry. He kept me from going absolutely ballistic. So yeah, soldiered on. I'm not exactly sure how I got here, but I'm here. So I do not want to touch anything that might impact that.
And Cindy, I shared with them that you're having your own home health moment at this time, and I answered question 1 with a yes. It's in the chat. Yes, you do have to get a PT eval signed, and I explained why about what that patient's picture looks like from point of view. All of that does not make it to the plan of care, and so that does need to be signed, whether it's done on day 1 or day 15. I mean, it can be embedded into the OASIS, but there's a whole separate level of evaluation. Did you have anything to add to that answer?
No, but I do have breaking news. The home health admission is occurring in the other room as we're doing this.
Oh.
So just for those of you who have participated in these before, I'm being good. I told the admitting nurse that I am the daughter here, not the home health person, and I'd stay out of her way. But I do have an ear to the wall just a bit, just to make sure that, especially when I was told yesterday that the admission wasn't that big of a deal, it should take only 30 to 40 minutes. And I'm like, oh, okay, but we'll see.
Those of you that have had to use home health in your personal life, I hope that you're having a better experience with it that Cindy and I have historically. It is very difficult to stay out of the way and allow them to do their job. And it's very difficult to see when your loved one or even a friend or a personal contact, somebody that you know, an acquaintance, doesn't get the level of care that they deserve. And so, Cindy, God bless and Godspeed, man. That is not easy.
But I do think those of you who have done it, you can relate to, especially the people like me that are passionate about OASIS accuracy. When you're on the family side and you know the truth about certain parts of that situation, and then you watch the assessing clinician ask questions only and take answers at face value. And it's like, this has always been the problem fundamentally behind OASIS accuracy is just blanket interview and assuming everybody's telling you the complete truth can give you answers that are fundamentally wrong. Because if there's a cognitive issue, if there's I'm resistant to really discuss the complexity, or you don't actually make them get up and they tell you how great everything is, you can see why we end up looking at it on the review side going, based on this description, these answers don't make sense. That there has to be something more going on. So I will check my emotions now between that and then the tech problem, but I'm ready for our questions today, Sherry. So let's get to it.
And I wanted to give everybody the opportunity to, if we didn't answer the first one as full as you wanted to hear it, please let us know. You'll get our emails at the end and reach out to us and let us know if we needed to clarify that one a little bit more. But I'm going to move on to the second question because we have several. And these are some good ones this month. Managed Medicaid. Are you aware of any guidance on duration of visits and the use of units for billing? I am unable to find anything in Minnesota guidance in MN guidance manual. I assume that was Minnesota. We have a contract with Aviana in Chisholm Hibbing location, and they instructed their therapists that treatments need to be at least 45 minutes as they pay in 15-minute increments, and the agency needs 3 units per visit to break even. I also looked through AID and skilled nursing visit guidelines and was not able to find anything that outlines the specific duration of a visit or the use of units. Home health is typically per visit.
Well, that's a long question, but I think it brings up a very interesting issue, is that how long should a home health visit be? And I admire the person who sent us that question because they clearly have been doing digging. And that's an important thing, I think, in any situation when someone says we have to do something or we can't do something, to really look for a reputable source to make sure that this is coming from real regulation or real policy and not just somebody maybe potentially misremembered something, or it was true years ago, but it no longer is. The issue around the 15-minute increment, and Sherry, you can chime in here, as a former agency owner, is that when we submit a claim, we do still report visit length in 15-minute increments. But as the question asker discovered in digging in all of those places, there is no specified visit length associated with any of the disciplines. Now, to me, that has some positive factors and it has some risks, because positive means they're giving us leeway, because it is correct, we're being reimbursed per visit. They're giving us some leeway about how long that visit might take. But some of the risk is, without a minimum, is there a chance that these visits may systematically become too short? And historically, this was an issue raised specifically to therapy visits because of the concern that the number of therapy visits were impacting reimbursement. That was there a temptation to do fewer visits? And without disclosing too many details, I found myself in a situation as a rehab director of facing the question, well, if the therapist is already going twice a week for 45 minutes, why can't they just go 3 times a week for 30 minutes? So it's the same 90 minutes of therapy, but it will register as 3 visits instead of 2. Needless to say, I did not accept that as a policy going forward. But where that all came from is they were tracking the average length of a therapy visit when they started this whole therapy visit counting. And the average at that point was about 48 minutes. So the discussion around a 45-minute visit really comes from historical information said that was typically the average. Unfortunately, when they implemented the therapy visit counting, that average dropped, which continues to feed the CMS beast about behavioral adjustments and people doing things they shouldn't do in response to payment. But it raised an issue of how long should our visits be? We want to see a reasonable average, but it has to really be looking at the discipline involved and what their tasks are. So if you have an admission clinician who's spending a lot of time doing these admits, obviously their visit length is going to come out longer. What I tend to do in this situation is say what we have to watch for is visits that systematically seem very short. I've done some audits and every visit is never longer than 30 minutes. So you can see from the payer side, if I'm paying you a lump sum to manage these patients, and now it's a bunch of teeny tiny visits, you start to wonder if maybe we're trying to avoid a LUPA by doing a bunch of short visits instead of a couple longer ones. Now, the people on this call are going, you're insane. I wouldn't do that. Oh gosh, it's always the bad apples that mess it up for everybody. Yes, that's very true. So that's a long-winded answer to get to this point. Sometimes there will be very short visits, Sherry, that are absolutely allowable. The one that I get a lot of,
If you walk into a home and your patient's on the floor and you immediately go through your ABCs and you call 911 and within the first 5 minutes they show up and take over, that is a skilled visit.
Yes.
Because you assessed whether they were alive or dead. I mean, that seems like a silly thing and it seems like an obvious thing, but we get that question quite often.
Well, the variation we get, Sherry, too, is it really a therapy visit? If the therapist got to the home, did the vitals assessment, determined that the patient was having problems, did not feel that the activities that they had planned to do were safe, contacts the physician about the vital sign anomalies and provides follow-up to the patient, but didn't actually do, quote, therapy, is that still a skilled therapy visit? Absolutely, because it took skills of a trained professional to determine it was not safe to do certain activities that day.
Exactly.
And the follow-up to the physician is part of that skilled follow-up. So this whole discussion of a visit has to be 45 minutes has also had the flip side of, well, in these cases, those aren't real visits. Yes, they are. If I provide skilled services to alert the medical professionals or adjust what I have to do based on my findings, and I document that well, there should never be pushback about a visit that is that short. What we have to watch for is when it's systematically short,
Right.
when visits are never longer than a certain amount, or they're always 30 minutes on the nose. That one I don't understand, Sherry. How is that possible in home care that every visit is exactly 30 minutes? There's no way, even time in, time out of 12:02 to 12:32. I'm like, I'm not even sure the EMR is time stamping at this point. So I still would encourage the specific question asker to take this approach. Whoever is telling you there has to be a visit length and you've looked everywhere and can't find it, the onus I would put on them. Whoever is saying you have to do it, I would say, can you please show me where you find this in regulation? Because I've seen people get very frustrated and spend a whole lot of time trying to find this mysterious regulation coming up empty. And I would say, if I've done my due diligence, then I think the next step is fair to say, whoever keeps telling me this is a rule, they need to show me where that's coming from. Because if they also come up empty, then maybe we need to have a conversation that it's not a real rule. But if we need to track visit length and we need to make sure we're not doing a bunch of short things, we're happy to do it. But then we need to stop calling it some sort of Medicare rule.
100%. And I just want to caution folks to please not ask that question of Medicare. This is where they're silent, and we want them to remain silent because we don't.
Yes, we don't want to suggest a minimum visit length.
No, we don't. But I am going to draw people back to one word in the question that was asked, and it says manage. Well, two words: managed and Medicaid. Managed means that it's likely a HMO type situation or a managed care Medicaid, like almost like a Medicare Advantage type situation. And private insurance companies like that can put a minimum amount of time that they need to see that patient.
But they have to show you where it's coming from.
Right.
Because
but for their payment policies, Cindy, they can set payment policies however they want, and they can say to you as the manager of Medicaid, they can make actually more rules. And so I would ask for the specific guidance in their rules to make sure that it's legitimately something. And the other thing is electronic visit verification. That's also in Medicaid. And so you want to look at, when is that electronic visit verification occurring, and is it a time in, time out situation, and what does that equate to? So if you look at yourself as a home health clinician, when you walk in the door is where the time clock should start with a patient, and as you walk out the door, that's when that time clock should stop. In electronic visit verification, I would just be really aware of when that occurs, because that's going to make a difference in what your time is going to show. Any other comments, Sydney?
no.
Okay, next question, and it's another doozy. Surveys and completing home health evaluations. We are going through some difficulties with OT staffing and are needing extensions to get our evaluations completed outside the 5-day window. Some are related to patient requests, others due to no one available to cover the evaluations. Agencies are voicing concerns with getting tagged on this during their surveys. We are doing our part to document when patients request delays in evaluation and notifying the physician. Our agencies are well aware of the staffing shortages we have. Is there anything else we can do to prevent getting tagged during a survey? When the agency accepts the patient and admits them to services, they are agreeing that we can meet their needs. Should the agency be letting the doctor know the delay in therapy? Patients are being made aware of evaluation dates and times, but unsure who should be letting the doctor know and what process to follow.
Okay, take a breath, Sherry. That was a long one. It has multiple components. First, I want to address the outside of the 5-day window thing. There is no requirement that once that patient is admitted, that other disciplines evaluations have to occur within a 5-day window. So I just want to dispense with that we have to get everybody out there within 5 days is not a rules issue, but it is one in terms of, are we providing the appropriate level of care? So if this patient is a high acuity and we believe they have significant needs for OT, then you would expect that to be initiated timely. When it starts to lag, then you start to say, but wait a minute, if the person really needed it, how could they wait 2 weeks before the evaluation? Now, sometimes it's intentional and clinically driven. I've seen situations where the patient has PT and OT ordered together and the patient is just overwhelmed. I don't want all of this, or I really feel terrible. I can't really participate in both, where the agency has made the decision to send one of the therapies in, let the patient build up a bit, and then add the second one. So that is a clinically driven situation, and with proper documentation, we can make it very clear why one service started later. When we move to the next part of this question, we're now dealing with a situation that kind of combined a patient request versus a true, we inform them we don't have it. So let's start with the patient request. If I have an order and I am the OT and I call that patient, let's say the quintessential example, I call them on a Friday and I want to set up an evaluation and they hem and they haw and they say, you know, I just got out of the hospital. I don't want to do this till Monday. Okay, we legally cannot go kick their door in and make them take that evaluation sooner. The steps in that case, though, are yes, we're going to respect the patient choice, but we also have to remember the doctor ordered it with an expectation of it getting done timely. So if the patient is requesting, I want to wait, we document it internally, but we always need to close that step with the physician's office. And I know in my time in this space, clinicians will roll their eyes at that because they're like, what's the deal? The patient said next week was fine. Yeah, but it's a patient you haven't even seen yet. So
Mhm.
you're taking their word for it that they're fine till Monday. The need to let the physician know we are going to start this on Monday is giving them the opportunity as the driver of the care plan and the overseer of the care plan, the opportunity to say, no, I don't think it can wait that long.
Mhm.
Now, does that happen, Sherry?
Mm. Not really, not.
You got better odds of seeing a unicorn. But from a compliance standpoint, if a surveyor looks at what appears to be systematic, and I just have to share, in my previous life, I noticed there was a lot of evaluation Friday that got punted to the beginning of the following week, to the point where I'm like, are really all these patients requesting it, or do we have something else going on? But we need the documentation of the patient request, and we need an update to the physician to say this is when it's going to start for the opportunity to make sure everybody's on the same page. Now the staffing part. Fully understand, and although the question asked is specific to OT, we really can run into this with any discipline. The issue that we know we don't have enough of them, and what are we going to do with this? Well, clearly, we need to make sure our intake department is aware of this so that if a referral comes in and it includes, in this example, OT, we're able to be upfront with the referral source. So let's say they've ordered nursing, PT, OT, and speech. And the intake person says that's great, but OT was running a bit behind. Is it okay if they start, the following week? And the referral source says, great. Okay, but who are we actually talking to? Because if we're changing the order and we're putting a delay in it for OT, then if I'm just talking to a clerical person who's talking to my intake, we do need to show evidence that the physician has been looped in about the delay in service. So that, because this is not a patient reason, this is an availability reason. And I've seen this with, we don't have enough speech. Well, okay. And you know that by following the rules, technically speaking, if we take on a patient and we cannot provide the services that they need, we have to disclose that to them. That even took up a bigger issue with the alterations to the COPs about public facing disclosing of our delays. But we have to make sure the physician is ultimately okay with that delay. What concerned me at the very end of the question was I'm not sure who's letting the doctor know.
Mm.
We do need to make sure that that happens. So documentation and communication with the physician that there is going to be a delay so that we're able to show that one, we are disclosing this to follow the larger COP, that if we know we're behind in OT and this is going to be going on for a while, that needs to be public facing so that patients have choice. Because technically then, if they want OT faster, they should be given the option to choose another home health agency. And Sherry, I know where they're going. Nobody has enough OT. They can't get it any faster than anybody but me. Understood, but it's still about patient choice. If they're told at the time of the referral that OT can't come for 2 weeks and somebody says, no, that's not acceptable, they have to be given the right to choose another home health agency, regardless of similar staffing problems potentially. If they're okay with it, the doctor's okay with it, we're fine. But it does become something we have to watch in a slightly different area, and then get I'll get off my soapbox a little bit there, Sherry, is the problem I've seen with when we're behind on a service is sometimes then by the time we get another one, we still end up behind. Because I think what happens in that situation when we know we're short-staffed in a particular service is care plans can become more triaged so that in this example, let's say I have two OTs, I really need a third one, we're running behind. So OT starts writing plans of care for twice a week that they would have done 3 times a week at the beginning, but they're trying to get as many people in there as possible. So the phenomenon then becomes we get the third one and we're still behind. How did that happen? Well, maybe what I needed to be going after is 4. So I have 2 more, not just 1 more. So within the agency, there needs to be good communication during these triage times of I know what we have to do to make this work, but I don't want to lose track of, are you curtailing frequencies or shortening durations or discharging good enough in an effort to try to serve as many people as possible? What do we really need to be able to provide the level of care we want to provide?
And Cindy, I'm just going to encourage everyone that first of all, you should have a full rounded OT program. OT is so crucial to home health patients. It is one of the best services that you can provide to your patients to allow them to take care of themselves and to get their agency back after a serious illness or injury. And in the other services that are highly used in home health, for a nurse, you have an LPN that can do the daily visits. And for a therapy PT, you have a PTA that can do some daily visits. And that came about because you needed the availability of the gatekeepers. And those gatekeepers are the 4-year licensed folks. And in the case of the PTs at 6 years. And those are the licensed folks that can do the intakes. And so go out and instead of hiring 4 OTs, hire 3 OTs and 2 COTAs, certified occupational therapist assistants. In my experience, they are fabulous and they know how to take care of a patient. And
Sherry, you dropped off.
no, I know I interrupted for a second, but I want to encourage everyone to fully build out your OT service. And when I owned my agency in the mid 2000s, we often led with OT. As far as front loading the visits, especially to get folks who were not able to do self-care, who were not able to reach their bum, to wash themselves. Those kinds of things are so crucial to how you feel about yourself and how you heal, and making sure that the patient is clean and things like that. And so oftentimes we would, in that situation, we might delay PT, gasped, clutch the pearls. What? Yes, we delay PT and let OT take the lead to make that patient more excited about getting better and able to get away from some of the mental aspects of coming home and what the transition's like. So, Cindy, did you have any more comments?
I do have something personal to add to that. I think sometimes when we look at the referral about who we're going to triage from a therapy standpoint, we sometimes still get stuck in the orthopedic patient should always go first. Those hips, those knees, they need therapy first. And some of these other more general medical, just kind of older people can be the ones that wait. I would strongly disagree because particularly with elective joint replacements, these folks tend to get very focused therapy on the inpatient side and very specific things that they need to do and take care of, and a lot of instruction and programming around that. That may mean, I'm not saying we arbitrarily flip the script, but I see too much of ortho goes first, ortho gets more. In the case of my family member, I was looking over the discharge paperwork and it talked about, her ability to walk, her ability to bathe, her ability to dress. But then in the fields about ability to prepare a meal, not assessed. Ability to do laundry, not assessed. A basic ability to do homemaking, not assessed. So this is a person coming out of a rehab setting to go home and live alone, that they never touched those things that you have to do once you get home. Who's making the meal? Who's going to fold laundry? They never addressed it. So I think sometimes we look at those kind of cases and say, well, they were in rehab, they got stuff, they'll be okay for a while. We don't have to do this soon. I'm not sure we're necessarily making the right assumptions. So in a short staff situation, I would strongly encourage some sort of questionnaire or review of the documentation if they're coming from a facility side to see what really may have occurred to help make that prioritizing decision and not make it solely off diagnosis.
And if you're having trouble trying to figure out what strategy you want to take in that situation, it brings me back to Dr. Miller and TYM coaching. Great leadership, it can make the decision making process much easier. And one of the things that Cindy and I see a big dearth in home health is leadership. We oftentimes in this setting will promote people because they're great home health clinicians, and then we worry about their leadership skills after. And oftentimes, and you guys have all experienced it, where someone is promoted to a position that they are not able to sustain. And part of that is because they've never been taught what makes a good leader. They've never been taught the processes of leading. And so I think it's important that you take a moment, invest in your middle managers and your upper management, and invest in some of your clinical leaders to show them that there is a process to leadership, and that everyone who wants to go out and seek that acumen, they can get better in it and more skilled at it. And so we highly recommend Dr. Miller, another woman-owned business. And so I want to make sure that everyone has an opportunity to see this slide good. And I wanted to get to a couple of hot button questions that aren't so long, but thank you again, everyone, for submitting your questions. And please use the chat box if you have any that pop up during this call. So here we go, Cindy, you ready?
Yep.
Two of the biggest hot button ones right now. Just to clarify, we are now able to once again accept telehealth audio and visual visits for the face-to-face for Medicare patients?
Yes.
Yes.
That's a lot shorter answer than the other. Although, Chair, I do appreciate some of those longer questions because they really make you think about different elements and lead to other pieces. But yeah, sometimes it's nice for the short. Yes, that was fixed. I know that was a bit of an awkward window of, wait a minute, during the shutdown, we lost it, and would we get it back retroactively or not, or what am I going to do? Thankfully, it's been taken care of, and we're back where we started with an
And
extension.
hopefully, if we all get involved and we all push for it, that it will go on longer. That it has another deadline, though, Cindy. The deadline is on January 30th, 2026. Another weird deadline, you guys. Why wouldn't they say February 1st? I don't know. Or maybe even January 31st. But January 30th is the deadline. So if you have a moment, reach out to your representatives in the federal government, your Congress people and your senators, and tell them how important it is for your rural patients, for your difficult to transport patients, how important telehealth is to their overall health. We get lumped in with all the other telehealth providers. And so making that face-to-face, that's one of the things that we can do easily over telehealth. However, there's other items that our patients need that telehealth has been a big, big boon for. So make sure to take a moment and still advocate for that right.
Yep.
Any other comments on that one, Cindy, or are we moving on?
No, we can move on.
Okay, your favorite. What is going on with the OASIS Q&As?
Well, hot breaking news, the October 2025 dropped today.
What? Awesome.
Yeah, like today is in, haven't even had time being up to my neck in real life home care today to go through it all. But I'm looking at it. Oh, and they're leading with, does OASIS need to be collected and submitted for Medicare Part B outpatient therapy? So they made it the question one. That was that faux pas that happened when we went to all payers, when they told us that outpatient in the home also applied to this, and the Alliance got involved and made them realize their mistake. So we can see where this delay has now almost made question one humorous, because it's like, been there, done that, already took care of that. It's several pages long, which we haven't had as many of those of late, but definitely hot off the presses. Take a look at them. Because they're still dated October, so they expect us to be implementing these, and I know in the midst of everything else. But at least with OASIS, we know that there are changes to it technically, pending the final rule is April 1, so we can use the Q&As as a happy holidays. Let's do a few reminders about key OASIS topics, and I think you can make it a little humorous with the whole, we finally got the October ones at nearly mid to late November.
And I wanted to encourage people that if you're thinking about implementing what you see in those Q&As and you want to make sure that you can recoup billing from 10/1 to when the government opened back up that you maybe got denied on due to a telehealth face-to-face or other issues, reach out to Healthcare Office Solutions. They are a one-stop shop for your back office issues and those types of problems, particularly resubmitting claims and altering claims and looking at your T return claims. These folks can help you. I don't know that they do regular everyday billing, but they can fix the issues that you're having with your claim submission and your receipt of funds. So reach out to Lori and her team and see how they can help you. And another woman-owned business that we're highlighting this month. And I wanted you guys all have a chance to reach out and have a chance to look at the QR code and get that website up and ready for everyone. Any other quick questions on those Oasis Q&A, Cindy? I know it's killing you not to know more about it while you're.
Yeah, and it's also hard when it's pulled up on my phone and it's itty bitty tiny. It looks like there's quite a bit of discussion around the falling questions.
Ah.
Yeah, quite a bit.
So we won't give you dead air, but suffice it to say that Cindy will have this under her pillow and we'll have it in the computer that is her head within minutes after we get off this call. Okay, next question. Are you ready?
Yep.
Number 6, B1000 vision. Clinicians are choosing response 1 impaired, sees large print, but not regular print in newspapers, books, but the only thing documented is that the patient wears glasses. Does this support number 1, choice 1?
Well, some folks may get, kind of a double dose because we did talk about this on a recent Club Oasis meeting, is that there seems to be a little bit of confusion around the issue of glasses. We know that the old vision question it talked about what was allowable and glasses were, but magnifying glasses were not. Magnifiers were not, but they are now. I think it's a good time to revisit this because what we're in talking with our Oasis review team on the outsource side, they've noticed a trend of vision being scored as there's a problem, and the only thing in the assessment is that they wear glasses. And wearing glasses does not meet the Oasis definition of an impairment. It tells you if they have glasses, you're supposed to make sure they wear them when you do the assessment. So we just want to make sure that there isn't a misstep that glasses mean you're visually impaired. And if there's more to it than that, then you would want to see a bit more documentation that it was assessed to meet the criteria of response 1 and not just drawing an automatic line because they have glasses.
And they also make small pocket size cards that you can do vision tests for large versus newspaper print. You can print those or go to the Lions Club in your local area. They are a charity that's devoted to improving vision and providing alternative vision structures for those that have lost their vision. But oftentimes they will have those cards available. They're very handy if you need to assess somebody's vision. But then again, that takes not just interviewing, right, Cindy?
Right. Mm-hmm.
Okay. Now that accounts for them if they have glasses but do not use them, but this needs to be noted, correct?
Yes. I mean, if it's one of those where they truly never ever wear them, because it talks about what they routinely use. I mean, if you're in an isolated situation where the patient has them, refuses to wear them, and then as you assess vision, there clearly is a problem, I would absolutely document there is a visual problem and note that they have glasses and choose not to wear them. Or it could be a situation they have glasses and cognitively, they just keep forgetting to wear them and don't wear them. So the majority of time they're trying to visually function, they don't have the glasses on, then I would absolutely identify that as a problem.
Absolutely, and that would take you to 1710 and have you questioning what's going on in those answers, correct?
Correct, if they're not remembering that kind of stuff.
Okay, so next question. We're flying through these, Cindy. We've got about 15, almost 17 minutes to go. Here we go. Does this patient, M1340, does this patient have a surgical wound? If there are scabs present so that the incision line cannot be clearly seen, can we choose response 2, surgical wound known but not observable due to a non-removable dressing or device?
I've seen this issue pop up again. If you just think about what you read, Sherry, that if we're choosing non-observable, it flat out says due to non-removable dressing or device.
Yes.
So scabs, I mean, and I know some people can really get in the minutia. Well, scabs aren't removable. I'm not suggesting we're going to rip the scabs off to take a look underneath. We could have all kinds of problems there. But that response of saying surgical wound no because it's covered in scabs would be incorrect. Yes, this patient does have a surgical wound, but you cannot choose the response that says due to a non-removable dressing or device, because that's not what scabs are. So you'd have to assess that wound properly. I'd probably be leaning, without a full description, leaning toward the not healing response because we've got drainage and potential issue going on there. If it's all scabby, then it's highly unlikely epithelialization is fully completed. But I would definitely not gravitate toward scabs mean it's non-observable because the response is very specific to non-removable dressing device. To that end, though, if we do have a situation that there is in fact a non-removable dressing or device, we do expect to see that there's a physician order or physician documentation to support that they have said you cannot remove it. I've seen clinicians use this response because the patient didn't want them to do a dressing change, or the daughter just changed this bandage and I don't want you to mess it up. Well, unless the daughter's also her doctor and said, you can't remove it, clinician, those don't meet that expectation either. So I know there's times I get pushed back to say, but the patient doesn't want me to do this and they get upset with me. Okay, we're going to try our best, but I think some of this can be a scripting that in order to provide the best possible wound care for you, I need to see that wound. So I know where we're starting from. I'm just going to take a peek at it. I will put the dressing back. I think there's ways to mitigate that. And sometimes I think in a hurry, the patient just says, I don't want you to touch it. And we go, okay, non-removable dressing. That technically isn't, just because the patient doesn't want you to touch it.
And anybody on here who has additional and extra wound care training, please bear with us using the word scab. That's how that came to us. A scab is eschar.
Right.
And so eschar, we don't know what is beyond eschar unless we open that eschar up. And a lot of times we have to consider an enzymatic debrider. We have to consider things that are going to bring that, or even a mechanical debrider, which is kind of old school, but something that can bring those scabs off and make sure that there's not any tunneling or non-healing that's occurring beneath those scabs. So having a fresh policy in place to say, what is your policy? How long do you think that this needs to be scabby, if you will, or what percentage of eschar is present? Use the word eschar in your notes. That's a very technical term, and it's a way to show that your skills are necessary because eschar can be hiding a lot. So,
well, and Sherry, that's why, you know, it's an answer to a point, because I would want more clinical detail.
absolutely.
It's called scab. Is it really adherent eschar, or is it like dried drainage that if we appropriately cleanse the wound wouldn't be there?
Exactly.
Would be less of it. So I think that there's some nuance pieces. I just wanted to drive home that when we're going to pick that non-removable dressing or device, that really is a physician order supported situation, not just I've decided I'm going to use it for other reasons.
Exactly, exactly. So use your big college words though when you're documenting this stuff, and make sure you measure it and take images if and when you possibly can, because that's always a good idea to get to healing as fast as you can, or to identify issues as fast as you can. So I think that's in the best interest of your patients. Any other comments on that one, Cindy? Because we got another surgical wound one coming up right behind it.
All right, bring it on.
Okay, M1342. I've seen some recent guidance that a fresh surgical wound should always be coded as non-healing in M1342. Is this a correct interpretation?
Technically speaking, it is not. We have run into some recent issues on our outsourcing side where folks are citing information that they've read that are trying to connect in an always situation that a fresh surgical wound means it's not healing. That does not follow the guidance. And anyone who's been at any of my sessions probably is already knowing kind of what I'm going to say, that anything that goes always or never, show me where it is an official CMS guidance.
Right.
And in this example, the guidance turned out to not be from CMS. It was an interpretation made by a particular company, directing it toward this would establish, you know, better baseline, which kind of reads like we can make it look worse so that we have a better shot of improving the surgical wound. So it's a little sketchy from that perspective. But I just want to touch on that because this isn't an isolation. We just want to make sure that this idea that if I'm looking at a fresh surgical wound, I can always make them non-healing by default is not what's supported by the official CMS guidance.
And Cindy, I want to interject here another clinical point. They're using wound glue a lot of times in these smaller surgeries, like abdominal surgeries. I've seen an inch long incision be closed completely with wound glue, and it's clean as can be. It's not even, it doesn't even show inflammation as far as where the surgery occurred. And those can be put as newly epithelialized, because if you don't have those clinical presentations of it not being newly epithelialized, jumping automatically to non-healing is not clinically appropriate either.
Well, especially because in the case of surgical wounds that are held together, whether it's wound glue or staples or sutures, we know that automatically the granulation responses are off the table.
Right.
So we're dealing with either newly epithelialized or not healing. So I think the opportunity still remains that if what I'm looking at is being held together, but I'm also noting some drainage. There is a scab, there is things on the dressing, then clearly that is not newly epithelialized, because if it was completely held together and epithelialized, it couldn't leak. So in that situation, we still see a lot of need to, encourage a correction, because if there's still drainage, then it's not completely epithelialized, and that makes it non-healing by default. But the nature of the question we got was just saying, if it's a fresh surgical wound, regardless of it's held together or whatever, you always make that not healing. That's an overreach compared to what the guidance tells us.
Agreed. And be careful where you take your opinions from, and make sure that it's backed up by regulations that they can show you that answer in either the OASIS manual or supported documentation from CMS. I think that we oftentimes will hear something and we'll go, cool, that sounds great, and then implement it, but then we don't do the research to find out that it's actually legitimate. Is that a fair thing to say, Cindy? I hate I hate to be so negative about that, but you want to make sure that the advice you're taking is good.
And I'm not saying things are ever malicious or intentionally misleading. I think sometimes what can be misinterpreted or not remembered correctly can take on a life of its own. And so it's important that we just check the source documents and make sure that we're not, oh, somebody told me this, and so we're all just going to do it. We just want to be careful where that information is coming from.
Absolutely. The next one is a really hot button issue that we've seen a lot on recently. M1830, question number 9. We have about 10 minutes left, and I put up the slide with our information. Should you have any questions after we get off this session, please use our email addresses or go to our website, and hopefully that can help you. But our next session is going to be January 22nd. 2026, that's going to be a hard one to get for some reason, from 1 to 2 p.m. Eastern. So you have between now and then to register, and you have between now and then to submit questions. And when you submit your questions, just let us know if it's for the Q&A or if you need an immediate answer. We often will answer immediately when we get questions from folks that subscribe to us. And thank you so much for subscribing and being here today. Okay, M1830. In situations where a patient is unsafe completing bathing in the tub shower, even with assistance, can a clinician score them as a 5? How do grab bars factor into the discussion of safety when bathing?
So it's always been kind of that fine line in the functional assessment between we're looking at their ability, we're looking at their safety. What if they could physically maneuver their way into the tub shower and do this, but we're watching this horrified as the clinician, like, because we know that there's situations where the patient, is gonna do, this is how I do it. And we, stand there and sweat profusely and worry the whole time they're doing it. What we have to look at in those situations, as an example here with 1830, is as the assessing clinician, if I look at how they do it, and even if I gave them some verbal cues, if I physically help them, if I vet all of those things and I still think you using the tub shower is ragingly unsafe, and I am basically going to forbid you from doing it right now. Well, the patient's going to do it anyway. It doesn't matter. I looked at how you do it and what you have and what it takes, and this would be horribly, horribly unsafe. I have the option of choosing a sponge bathing response, okay? Now, I'm choosing my words carefully, the option, because it would be up to that clinical judgment and significant documentation that despite your best efforts in this current situation, this person should not ever be in that shower doing these activities. Even if somebody was here with them, no. Okay? That is a very unique situation and has to be well documented. What we see at times is a little bit of coloring outside the lines. So trying to get to this by saying, well, if the patient has grab bars, then there's a safety issue. So we should go ahead and make them 5, saying that they need someone involved with sponge bathing. Now, this is where I have the problem. Just because there's grab bars doesn't make them an automatic 5. If there's more to this, if there is grab bars and here's all the issues that concern me, which is why I picked a 5, I get it. But there's times we see based on the documentation, and I totally acknowledge it could be details are not being documented properly, but we've seen trends of the only thing noted is a grab bar, and they immediately get put as response 5. The same variation on the theme, Sherry, of they're putting down a visual impairment, and the only thing they put is glasses. So if there's more to the story as to why you picked a 5 or why you said there's a visual impairment, we're not going to write War and Peace, but you can't just say the person has grab bars, therefore they're a 5 as a baseline. Because there's people with grab bars that have had them forever and know how to use them, or they were installed for someone else in the home and now this person is not doing so well. They're able to say, we can't just take a piece of equipment and give them a higher acuity level based on it.
Exactly. And we most oftentimes see folks underscore this item, and they will, and remember, and just Cindy, can you please reiterate your famous statement of what independence in the shower means and where you would be in the case of a person being independent in the shower?
Well, that's where, again, looking back at the discharge paperwork I was looking at earlier today, to just arbitrarily say someone is independent. I'm like, no, this person has some cognitive issues. This person has balance issues. There is no way I would let that person into the shower without at least supervision. Yeah, I know body parts move and they can use the tub seat and all the other things, but in the home, this can be very different. And I think someone should at least be with them. If we're going for independent in any of these functional assessments, we are going for top of the line. This person performs that task so magnificently that they don't need anybody for anything at any point in time. For bathing, they could take a shower at 2 o'clock in the afternoon or 2 o'clock in the morning. I could care less. They've reached the pinnacle. Independence is the pinnacle of performance. There is nothing higher. So when I see independent but, it drives me crazy. There is no independent but unsteady. Independent but unsafe. That one nearly gives me a stroke. Independent but requires repeated attempts. There's no but. So as a clinician, when I drop independent related to anything, that means gold star, seal of approval. It's so wonderful. It's not going in my care plan. It's not going in anybody's care plan. Yes, Sherry, I get very dramatic about it because I want to emphasize that is what independent means.
I think your famous statement, Cindy, was if you feel comfortable standing outside
Yes.
and watching them bathe, that's probably independent.
Well,
That's
if you feel like I could put them in the shower and I could go out and watch TV and I
Yes.
have no worries whatsoever, that's independent. The difference is, and we have to be very careful how we use that word independent because there's a huge difference between independent and does it by themselves. Does it by themselves can be completely accurate, and I could document you do it on your own. Independent is my blessing. And if I'm not comfortable giving my blessing, I will document you do it on your own. But if it was me, they need to be supervised. They need to have this kind of assistance. I'm providing this kind of assistance. They insist on doing it on their own, does not give them a free pass to the word independent.
Okay, we had a question that was submitted, Cindy, that I think should take precedent. We do have one more question that we're going to add in.
And I'm happy to touch that last one if we go a few minutes over. I know people might have to leave, but we can have it then into the recording because of my delayed getting in.
It's okay. Okay, so this one is interesting, and I think that you want to answer this one. Does anyone know why there are only 6 states powering through review choice demonstration? Will any other states get the opportunity to participate? They definitely can take their turns. Do y'all see us ever getting out of this?
Well, that has to be coming from a state that is currently enjoying that process. Because it sounds like you could condense that down to misery loves company. Now, I have to say, born and raised, not currently living in, but currently sitting in the state of Illinois, I know that that was one of the original states. And the bumps and bruises of getting it off the ground then led to publications saying that Illinois thinks this is great, that this
Yes,
is wonderful. And then it's creeped into
lies.
other states. And I'm like, it's that wonderful? Are you
Yeah.
sure? I mean, there's a lot of discussion about expansion and the perception being, is this really saving CMS money? Where some of it gets a little confusing is you're getting pre-approved, but then there's reports of audits still occurring, or I got it through review choice, and then another arm of this program pulled my records and denied me for things that I thought I got pre-approved for. So I think that's probably driving the, if they're not going to stop it, when does everybody else get it? I think with a lot of what's going on in the government right now, I'm not, in my limited interaction, I'm not seeing it as a big push area,
No.
but I'm not seeing it off the table. I think we're in a limbo of there's still, if you could see me, air quote, evaluating expansion. We haven't seen any indicator that they're willing to scrap it completely.
And it predates PDGM.
Yes.
And so PDGM was a sea change, and it left some vestigial things on there. And one of those vestigial things is the RCD. The other vestigial thing is at least every 30 days doing a reassessment, in my opinion. So I want to be clear, the states that are on review choice demonstration are Illinois, Ohio, Florida, Oklahoma, and for some reason, North Carolina. We never have figured out why North Carolina and how they got on that list due to the simple volume of work they put into that, but it's just interesting.
But if I recall,
I bet they wish, hang on, I bet they wish they had put California on that list.
but I think what it came down to, Sherry, is trying to get it off the blocks. If I recall correctly, and people can correct me if I'm wrong, they ended up going with Palmetto states.
Right.
They did not bring other intermediaries into the mix. And so I think that's why you see that mix of states, and other states that you think should have been included, but were not Palmetto states, didn't end up getting tagged in first.
And those of you that are on here and you might have additional questions, thank you, Cindy, for that. So and I'll answer the last one. Do I ever see you getting out of this? Yes and no. As long as people are still wanting to benefit share and pass patients from one person to, or one agency to the other ad infinitum, I think that that's a way that Palmetto and CMS feel like they can catch that early. If you have to submit a review choice demonstration, if you have to submit that ahead of time, that may be able to be caught sooner. What do you think, Cindy? Do you think it's ever going away fully?
I have never heard anyone I've interacted with say that it looks like it's officially going to go. If it does, it's not going to be anytime soon. Because there are proponents that believe it's the best thing since sliced bread. I clearly don't believe the person who asked the question thinks that. I mean, there's positives to it, but it's been hard to weed out what is the real benefit of this? Is it really worth expanding it? And ultimately, if you're not going to expand it, is it really worth to keep it in 5 states? But
Exactly.
we don't really know.
Exactly. And it's in 6, by the way, not 5, but hey, it's okay. And those 6 states are just lucky, I guess, sarcasm included. Okay, last question, and then we're going to move on. But again, if you get off of this or you show this to one of your teammates and they say, man, I wish we had asked this question, please submit those questions. Just hit on any of the links, go to knkhelp.com, hit the contact button and submit that question. Come straight to us and we'll take care of that for you. But we're a little extra time right now, and I want to encourage folks that this last question, if you have to go, will be on the recording and you could fast forward to it if you needed to. Okay, when I complete a QA review of a discharge OASIS completed by nursing, I look at any of the therapy discharges completed in the previous 5 days. There are times when the therapist documents the patient a better functional ability than the OASIS responses the nurse picked. So I changed them to reflect what the therapist said. I am now being told I shouldn't be doing that. What are your thoughts?
Well, we've seen this phenomenon both at the discharge and at the evaluation when it's okay. So at the start, we look at the evaluation and then the admission, and then look at any therapy evaluations in those first few days to see if there's a consistency in the functional assessment, and then the reverse kind of backing up off of a discharge. I think as a reviewer, there's value in looking for potential consistency. You really don't want to see huge differences of opinion between that admitting clinician or the discharging clinician and the therapy eval or the discharge. But we have to be careful because there can be time differences between it. So let's say I discharged the patient today and the therapy discharge was 3 days ago. Performance could have changed in those last 3 days. So we can't just say, I'm going to go take the discharge answers and change the nurse's ones. I think what we can use those for is to try to facilitate collaboration. So we know that the disciplines involved with actively seeing that patient can interact with each other to collaborate on the best response on those OASIS items. The issue is I cannot, as a third party, take someone else's documentation and then just change the other person's documentation based on what I read. That's not collaboration. So reviewing those evaluations or discharges and noting significant differences and redirecting it back to the parties involved to basically discuss it amongst yourselves and decide what this answer should be facilitates the appropriate collaboration. My concern, though, anytime I've been asked whether it's related to the start or to the discharge, is if we're just going to say that the therapy evaluation trumps the start of care and the therapy discharge would beat out the nurse's answers on the discharge, then if that's the position we take, we would have to be consistent with that. So very often it is, well, I use the therapy discharge answers because they actually were a higher functional ability than the nurse picked. Okay, but what if you looked at the therapy discharge and it was a lower level of ability
Oh,
than the
snap.
nurse picked? Because you can't pick and choose then. If the therapy answers are the right ones, then they're always the right ones. And I'm not saying that as a therapist. If the roles were reversed, I'd say the exact same thing concept-wise. Picking and choosing therapy answers at the beginning so that the patient looks worse, and at the end, only if it makes them look better, is a subtle form of gaming.
Yes.
And we have to be very careful about that. So looking at them, I'm not saying you don't, you do, but inconsistencies as a reviewer need to be pointed out for them to collaborate. But if I'm just going to do that only when it appears to work to our outcomes advantage, we need to be very careful about that being a systematic process because it could very easily be interpreted as a variation of gaming.
Exactly. And I on that note, Cindy, I also want to discourage the non-visit discharge epidemic that is occurring. I think that we all need to take a moment and decide that should be an occasional thing or even a rare thing that you're doing a non-visit discharge. But we've run into where it's a practices where it is a consistent thing and it's kind of a rare thing to have the in-person discharge. Do you want to speak to that real quick as we finish?
We did, for those of you who were in our last one, we did spend quite a bit of time talking about that non-visit discharge. So I would encourage you, if you were not able to participate, to go back and listen to that piece. Like Sherry said, you can look at where it landed in the chat box in terms of getting to the right point. But non-visit discharges are really meant to be a last resort, tried everything I possibly could, and I have no other option. But when it's, kind of what we talked about earlier with the OT situation, sometimes I'm afraid these non-visit discharges are, hey, Mr. Smith, I need to come out and do that final visit. I don't really want to do that. I'm fine. Oh, okay. And we just go with the non-visit discharge. I think part of it is, again, the scripting around. It's important for us to come out and do a final visit, wrap things up, make sure everything's taken care of. That's the whole point of the discharge visit. But I get concerned when I kind of see more than I would expect of non-visit discharges, that there might need to be some investigation into what's driving this. And how do we mitigate that this really is, in case of emergency, break glass situation? Because it can have significant impact on our outcomes and things, because we're having to use a previous visit and then trying to, all kinds of stuff. Yes, CMS has answered numerous times with the best they think we can do in that situation, but sometimes that really does not help us out from an outcomes perspective.
Thank you so much for that, Cindy, and thank you for such a great session, despite all our technical issues at the beginning. And thanks everyone for your patience and for your participation. We've had a great year of these, and we look forward to 2026. Starting on January 22nd is going to be our next one. And we want to be sure that you guys have the opportunities to submit your questions. And please have the best holiday season you can. I put this really fat turkey on here for everyone. And so we want to make sure that we have the opportunity to say thank you again for following us. Thank you for being part of our subscribers and part of our listeners. And if you ever have the need for any of our previous QAs, that was a great piece of advice, Cindy, to look in the chat box to get the timestamp for an answer. We do this consistently in each of them. I think for at least for the last year. I know we've changed some things as we've gone along trying to get better. And I want to have you take the opportunity to go to our YouTube channel and click subscribe. It will notify you when new things go on, but we have other things on there like our podcasts and previous educations that we have on there. So thank you so much for participating, and we'll see you guys in January.